And as the tradition of WIROC, we begin dot on time. Thank you everyone for coming here early morning on day 2 of WIROC MAX 2022. We are going to begin with the session, Intramedullary Nailings, Getting It Right and Pushing the Limits. And to convene the session, I call respected Gadegone sir and respected Sudhir Sharan sir to just take over the session. Thank you, sir.
Good morning, everybody. The dawn is here. I request Tanna sir to please occupy the place. Chandak sir, please come on the dais. Dr. Prakash. And I think Shivashankar sir is not there. Mukhi sir, you also please take the place. We'll be honored. So, I was asked to start with the case. So, we'll start the case. So, I put up simple case and my Sir, better, sir. And my disclosures is, these cases all have been done by third year residents at Sion Hospital in EMS. So I picked up simple cases. So first case is this segmental fracture tibia. So Gadegone sir, my first question to you. Supracondylar nail set has been asked by Chandak sir and it is at Nagpur. So will you wait or you will plan something else?
Yes, there are two ways of doing this surgery. You can opt for a plate fixation for both the fractures, or you can take a suprapatellar entry and do a nailing. You can also reduce the fracture, temporarily fix the proximal fragment first by unique article plate, convert into a single fracture, and then we can do a regular nailing also. But the nail should be high horizontal bend. It should not be more than 5 to 6 centimeter from the tip. So that is how we can treat this fracture. But if you ask me today, I will do a unique article plate first, then do a suprapatellar nailing regular.
Okay. Chandak sir, your talk is on entry point. So any specific guidelines to pass the nail so that the patient doesn't have pain post-operative at the knee joint?
So this is an ideal indication for a suprapatellar entry. However, I would be doing a regular routine infrapatellar entry. The entry point would be in line.
Okay, which is ideal to have a suprapatellar.
Yeah.
But I will do infrapatellar.
Because the reason is I am not very used to suprapatellar nailing.
Okay.
So I have my own reservations for suprapatellar nailing. So to answer that question, how I would proceed, I would first reduce the fracture, hold it with multiple clamps at apex, 2 clamps proximally. The distal fracture would be aligned, and then I would take an entry point in line with the lateral tibial spine and be as high as possible and use a suitable nail. That would be an expert tibia nail with multiple proximal locking. So that would be my philosophy for this patient.
Okay.
You said you have reservations for suprapatellar.
But he said that he is not used to
polite
it.
saying that I am not used to it, but Gadegone can do it.
Sudhir,
Yes.
is there any role of CT scan in this case?
Yes, Tanna sir can answer that.
I'll do the plating there. I feel the plating is far more certain than the nailing for this sort of a fracture to get the perfect anatomical reduction. Unfortunately, there is also a second fracture there, which I will extend the plate right all the way down.
Okay. So your choice will be plating. Mukhi sir, any combo offer?
Yes, I feel there is an avulsion of the cruciate ligament. I will do the CT scan. You see that piece and the hollow line there? One. Second thing, I'll put a reconstruction plate for the proximal fragment as well as the signal distal fragment, as Dr. Gadegone said, unicortical. Then pass the normal tibia nail. I'm not used to suprapatellar nail. Have you removed a suprapatellar nail? Oh my God, it is hell.
Okay.
Unnecessarily you will get a knee infection.
No.
One.
Removal is through infrapatellar approach.
That is what I'm saying.
Okay. Mukhi sir?
Oh, I don't criticize. I
Okay.
withdraw. I withdraw. Let me. Then I'll pass the nail. I will lock it. And then that reconstruction plate is a thin plate. It is to be passed with a mini incision and get the reduction, very good hairline. And after you have passed it, then you can pass the screws through the nail, transgressing the nail. That is my option.
Sir, you told cruciate ligament injury. There is no hematoma in the knee joint. It's still?
CT scan.
Okay. So you will ask for a CT scan.
See, the upper third and lower third fractures, 50% plafond fractures or lower third fractures of the tibia will be having intra-articular injury as well as the upper third. Literature.
Okay. Okay.
No, it's not that. There is a doubtful extension into the intra-articular, and there is a, you can see there is a shadow of the anterior tibial spine. You can see here.
So is it a true lateral X-ray of the knee joint, or you see some space between the patella and the distal femur?
So it's not a lateral true view because
Yeah.
the condyles are not aligned,
Yeah.
as well as the fibula is also not superimposed.
Yeah, sir. Marker? Yeah. We can appreciate. Yes. So, okay. Shiva sir, your plan, would it differ from one opinion has come about suprapatellar nail and other is about plating and capturing both the fractures? Any difference?
I will do suprapatellar nail, no doubt about that. But that doesn't mean that that is a treatment option. Whatever you are comfortable in doing, you should be able to do. So even in the proximal fragment, the fragment is very small. Even with the suprapatellar approach, the stability we might get is still questionable because of the oblique nature of the fractures. So I might think of putting a augmentation plate, locally small plate.
Okay. Prakash, your thoughts on that?
I'll prefer with plates only, both the fractures. But
Okay.
I'll fix definitely fibula also with a plate first
Okay.
to maintain the length.
Now here two controversies are here.
Yeah.
Mukhi says he is going to do a reduction plate, 3.5 or 2.5 millimeter plate, which is not an augmentation plate.
Yes.
While Shiva wants to do an augmentation plate, which is going to be a formal, long, minimum 3.5 screws.
I told first it is a reduction plate which can be converted into an augmentation plate.
Okay.
I said that. Once the
Okay.
nail is inside, then you can transgress the screws through the nail. They may be kissing screws or they may be locking screws as and when it goes. You touch the nail, go anterior to it, transgress it.
Okay. So, as I told you, the disclosure, this was operated by third-year resident in the EMS. So, this was what is done.
One thing more. Go back on the slide and you will see that there is a fracture here also.
Okay, let us discuss the tibia fracture.
Oh, this fracture is missed. This patient will not be happy.
Okay.
Yes.
Fine point.
Yes.
Yeah.
Why fibula plating? Why fibula plating नहीं बोला? Tibia.
Maintain the length.
No,
actually.
Prakash told about fibula plating, so that question. Okay. So, going ahead, this was what was done. Mukhi sir, are you happy?
This is not suprapatellar, no?
No, this is simple, yes, infrapatellar nail.
Sir, you are presenting means there is some complication.
Okay. Why do you anticipate a complication?
One is double fracture, second one is the fracture of the tibia. The shaft is little distracted.
Okay. Gadegone sir?
Because you did it, I kept quiet.
No, I told you,
President,
I have not done. This is done by third-year registrar in EMS OT in the night.
Then nicely done, sir. For a
Yeah, it was always consulted. Yes, I have been consulted and it has been done. Your comment on this nail, will it work, will it fail?
It will fail.
Okay.
Unhappy patient.
Day
Okay.
one failure or
Day one.
what is the cause for day one? What do you think? Why do you call day one?
Can you see it? Can you see?
Mike.
You see the obliquity here,
Yes.
right? And this as well as
That screw is interlocking bolt is working as an interfragmentary screw. Nicely it's
Yes,
working.
Yeah.
sir.
apex nail has come out in USA only.
Sir, let's talk about India. And you have told that this will fail. Gadegone sir?
No, it will unite because it's a cancellous bone if it is done nicely by closed method without disturbing the soft tissue. I don't think it will not unite because if it is done by closed method.
Okay.
So let us see because there are so many things they unite, but it is not properly done. That's what I can say.
Okay. Tanna sir, your expert comment?
No, I think it is very likely to unite with the small malposition of the proximal fragment.
Yes, because it's a cancellous area. Yeah, yeah.
Sambaram, mic.
Can we give a plaster and extend like that only and it will unite? Since sir said, Gadegone sir said cancellous bone, only problem issue will come mid-third, there is some gap at the fracture site.
Okay. Agastya
If you
sir,
give a plaster, it should...
आप कुछ बोलना चाहेंगे? Okay. Means?
Likely to unite.
Okay. Okay.
The question is whether people who feel that it is not likely to unite, are they going to revise? No. Correct. I am asking a question.
About the lower fracture which is comminuted, but it's been closed one and it has a fairly good hold in the distal part.
Yes.
So I think this is the one which could probably be all right.
Okay. The lower one. The lower fracture will unite first.
Fracture union is not the issue.
Okay. Okay. So this is at the end of 1 month. You can see this fracture is still being held by the nail.
Slight valgus.
Okay. Slight valgus, but still.
become more prominent.
And the fracture of the tibia and the fibula at the same level or almost the same level, I would also do a fibula plating as it was mentioned.
Okay. So Prakash, you have a good support. So this is at the end of 2.5 months. So 3 cortices are united. And this is the gait of the patient at 2.5 months. See, so you can see there is a maximum loading of the tibia. So any comment, final comment, Tanna sir?
No, I think you cannot doubt the success.
Okay. Okay.
Success should not be questioned.
Okay. Yes.
You show me the post-op last X-ray. Last X-ray.
Oh, sorry.
Last X-ray.
This one is the last X-ray.
And you can see the slope of the tibia.
Yes.
It has increased, so probably he will have early arthritis in future.
Okay. Yeah, that is a point. Okay. This is a...
Time is over, now we will go for 10 minutes is over.
Only 10 minutes. Okay.
So if
Just,
your time permits, next
Okay.
last.
Okay.
So
So you want to
first-
take this case or will...
We'll take the case within 5 minutes only.
Okay. So this is an elderly lady, 70 years old, on blood thinners, cardiac problem, and this is the picture she has come with us. She is already having bone disease, having fractured the tibia, and now there is a supracondylar comminuted fracture. Yes, sir. Any newer design, Shivashankar, sir?
Shivashankar will...
Yes.
See, basically, nail is always a biomechanically much more stronger implant compared to a plate. So, I'll be tend to use a nail. There seems to be intra-articular extension. I'll be opening by parapatellar approach the knee joint, get the articular reduction done, and then I'll put the nail. And I'm not worried about the supracondylar comminution. I'm only interested in aligning distal fragment to the proximal fragment. I'll blindly, without seeing the comminution, whether there is gap or whether there is only one side bone, I'll put the nail.
Okay.
Why do you want to open the joint?
Just to see the intra-articular reduction should be proper. Means
No, but
parapatellar
this
approach.
C1 type of fractures you don't need because this
Yeah,
fracture is extending into the intercondylar notch where you are not, it's not a weight bearing area where 1 or 2 millimeters is okay. So most of these joints, for C1 type of fractures, you don't need to open the joint.
But by opening the joint, you think you will harm the joint?
No, you're not, but it's not needed. If you are opening the joint, even if you do a plating, are you going to open this joint?
This intra-articular fracture, you're going to reduce that.
Intra-articular comminuted with C2 and C3 type, it's fine. You open the joint. Jigsaw
Anyway,
puzzle.
let's
you
agree to
close.
disagree.
Yeah.
But the message should be given properly. That's the reason why
Yes.
I might just put a small incision through which I feel with my index finger and put the cable. That's different.
You are passing a nail, isn't it?
Yeah.
Then you are opening the door. Open the joint.
It's a
Where is that issue?
infrapatellar incision, split the patellar tendon through a sleeve, we can do that.
Yeah.
But you have to feel the articular surface.
Open a little more, see the joint with your eyes, rather than exposing yourself to your radiation and getting a cataract.
मुखी सर, उसमें एक joint arthroplasty हो सकता है क्या? Can you comment? See the lateral X-ray. There is a arthritis out there also at the knee joint.
Primary arthritis should be avoided as far as possible. Treat the fracture first, let it heal.
Okay.
Heal.
Okay.
Once the fracture heals, arthroplasty becomes easier, results are good.
Yes.
Okay.
Let it unite, malunite, let it
But
unite.
if it was a non-union, then I would do that. But in a primary fracture, I feel it should be avoided.
Okay. So this has been done, and any comment, Chandak sir? Yeah.
So this should heal.
Recommended, no?
No,
Yeah.
not this. This is just a blade
We are
type.
not talking about your,
If
your
you
nail
have-
we are not talking about.
If you have a small fragment, you have to have multiple lockings in the distal.
Agreed,
fragment.
agreed.
Here also you should have added another two screws.
Need to have multiple lockings.
Okay. Okay.
And kissing screws also.
Okay, but do you feel this will not heal up?
Should heal up.
It will heal up. तो फिर 4 screw ही मांगता है.
Then you are running a race.
But there are full chances that it might not, it might fail.
You are running a race.
Okay.
Will you be comfortable making them walk is a question. Or are you going to keep them on the bed? On the bed, she might unite.
Okay.
But
I
that's
want the proximal part also.
Okay. So it's not there at present. Chandak sir?
Yeah. So this should heal. The contact at all the bony points on both the side is good. Alignment is good. And the stability is reasonable. So this should heal.
Will you comment about the joint line?
Joint line looks okay, fairly okay.
Okay. Okay.
Why? It will fail?
Because the bone is osteoporotic and that hold is not good.
Okay.
Distal hold.
Okay. Point.
Why joint line?
It's not sufficient.
Should the axis be considered in long bone fixation of lower limb or not? Yes. So, yes. Okay.
I think the contention is spiral blade plate which has been put is not a good blade plate. Is
Yes.
that what you're saying?
No, it requires additional support in an osteoporotic bone.
So, with a plate or additional screws?
Additional screws.
Okay. Thank you. So, this is after 3 months. So, as you predicted, it has failed. So, there is some amount of varus. But still, if you see the supracondylar area, there is a good consolidation of bone. So, will you agree with this? Yes?
No. The thing is that the nail is good. It wanted to unite, but you have
But
concept of
fix
nail,
it.
The nail.
Okay. Okay.
Show the previous X-ray.
Sorry, what have you done to the nail?
No. The concept of nailing is good.
But,
The nail, the model, the design should have been different.
Amit, please on mic.
okay.
So one point I want to make out.
एक माइक अमित को तुम दे दो.
स्पेशल दे दो एक माइक
वैसे जी एक माइक ले लो ना.
Concept, the design of the nail should be different, definitely, because this blade plate in a distal femur nail is not acceptable. And you had many other screws also, the holes, you could have filled those holes. But anyway, look, the fracture is really united.
Yes.
And it seems to be a good if you would have done a plating, probably it may have failed. You would have, not why, it would have required a primary medial fixation also. Yeah.
Primary double.
No, but there are,
You do a primary double plating. What's the problem there?
in a plating, if you see, there are so many people put a short plate. You have to put a
एक
long
मिनट,
plate.
तू short plate रखेगा
नहीं, मैं नहीं
तो
रखेगा.
फिर तो तेरी बात करना.
So what? 1 minute. We'll take an opinion of the house. How many will plate this fracture and how many will nail it? Platers? Okay. Okay. Nail? Okay. So there is a maximum crowd opting for nail.
So it means the majority is right, is it?
Okay. I don't. Okay. Mukhi sir, for want of time, we'll proceed. So this is the thing. And she is weight bearing in OPD. She is a home ambulatory. Will you accept this or you will go for?
Range of movements कितना है?
Oh, this is not my case. I have picked up. Yes. Okay. Okay.
Nail is in the joint.
Okay. Now let's take this question. Okay. Shivashankar sir, should implant be used as a reduction tool?
Yeah, it can be used. If you know how to reduce using an implant, it can be definitely used.
Which
yes.
areas?
Especially metaphyseal areas where the small fragment is there, if you are using a nail should be in the center of the distal fragment. Similarly, if you are using like distal radial plate, you can keep the plate off, then fix the distal screws in the proper direction. Then once you bring the plate to the bone,
Okay.
fragment.
Mukhi sir always opposes you. Let's see what is his opinion.
No, I accept this.
Okay.
Yes.
So as a reduction.
Yes.
Okay. Okay. Gadegone sir always ream long bones before putting a nail.
In osteoporotic bone, I may not, but in a young man, I will always do rim.
Okay. Tanna sir, backup implant. Suppose you have planned for nail. Will you always keep your plate ready or you will always?
I always have them.
Okay.
Always have them.
Okay. Okay. Chandak sir.
And maybe is not enough.
Okay. You can combine also both, combo offer. Okay, axis of alignment, is it important? Intraoperative consideration in highly comminuted fracture. Chandak sir.
Always important, always important.
So you always see it intraoperative after fixing it.
So the entry point as well as the end point of the fixation is really, really important.
Okay. Are all complications avoidable or are there scapegoats even after fixing it properly? This can fail, it means it is patient's related factor. Yes, Mukhi sir.
Yeah, all bones are filled with black ingratitude, not red marrow. This was the thing which was told to me. हाँ, ये जो bone है, bone very tricky bone है, osteoporotic bone, very difficult to understand.
Sir, आपके लिए question ये है.
हाँ, तो you can always counsel the patient saying that there is a literature complication. Rate in these fractures is more than 10%.
Sir, you have, question is not this. Question is you have fixed it properly according to all your
Still you can
thinking.
fail.
Yeah.
Why?
Almost.
Because I told you the bone is filled with black ingratitude,
Okay.
not with red marrow.
Okay.
Sir, almost 10% of the fracture, in spite of your best effort, especially due to osteoporosis, they fail.
Okay, quickly causes.
If you think that 10% is going to fail, would you not do an overkill?
Yeah, definitely.
Because I feel the nail and a plate has a far more assurance of healing than a nail alone or a plate alone.
Correct. Yes, definitely.
So I think that overkill is not a sin at all.
No.
That's
Okay.
why I came to the combo technique in IT fractures. Overkill.
Okay.
Yes.
Okay, 1 minute.
Yes.
Chandak sir,
I want
any
to-
patient-related factors? Okay, Mukhi sir, 1 minute. Any patient-related factors? Tobacco?
Definitely a harmful thing. Alcohol, definitely harmful thing. Not taking enough calcium, vitamin D, definitely harmful thing. Bone metabolic considerations always has to be looked up in all patients of fractures, especially in elderly osteoporotic. So
Okay.
that always
This question is for, yes sir.
Osteoporosis, is it an indication of a non-union or is it the factor for a non-union? No. So why the calciums and all you are bringing into the picture?
So basically because at this age,
Teriparatite we are not talking about.
so elderly osteoporotic, one of the biggest causes in India is a vitamin D calcium deficiency, which is rampant. So therefore has to be looked into.
Okay.
That osteoporosis cannot be corrected for months and years together, even with teriparatite.
It's a on.
Another.
Yes.
So there is no difference between osteoporotic bone and normal bone healing. Only we give adjuvant to the osteoporotic fractures, it's because he should not have a future fracture.
Okay.
Okay?
Point well taken.
Sir,
Now the
another
next,
patient factor is patient may not understand what we are telling. Sometimes non-weight bearing or partial weight bearing, the patient
Okay.
loads totally.
Okay. Now next question is for Mukhi sir. Now I have no complications as I have done enough number of cases.
That applies to Mukhi.
No, because I have failed multiple times, I have learned from that.
So now,
Now I have no complications.
now,
Can you say that you don't have any complications?
No.
now after being so senior surgeon, now you don't have any,
No.
you have?
Yes.
Okay. Thank you, sir. God on
He
the
is
side
fool,
of,
He is the fool who will say there is no complication.
yes.
Yes. And you have to be foolish and be inquisitive. Why?
Yes.
And that's what Steve Jobs told.
Yes.
Be foolish all your life.
Okay.
Keep
okay.
on questioning why it has failed.
Okay, sir, God on the side of the patient. You have done some mesh, still the fracture has united. And your experience.
In spite of surgery.
Okay, one final question. This I have put ding dong patient. Patient has been operated by A surgeon, he goes to B surgeon. B surgeon tells, okay, thoda plate dalna chahiye tha, this, that. Again that patient comes to A patient. Your reaction being surgeon A, and Gadegone sir, your reaction being surgeon B.
मैं डिगडॉग पेशेंट को ये बोलूंगा जो भी उसने किया है वो अच्छा किया है, तेरा नसीब है कि वो अच्छा नहीं हुआ, मैं थोड़ा सा अच्छा कर सकता हूँ.
Okay, again he comes back to Shivashankar sir, yes.
Yes, that is also an option because मैं ऐसे example देता हूँ अभी पुणे से बॉम्बे जाने के लिए you can go by train, you can go by flight, you can go by car. So that is also one of the option. Yes, we'll keep watch and we'll see what best can be done.
Nice. One final comment from Tanna sir on this. Mukhi sir ने हाथ उठाया है. But
I think each one of us needs to update. The excellence is a lifetime situation.
Yes.
It cannot be that Mukhi has done hundreds of cases, he will be all right. The science is changing, we all have to update almost every time.
So, motivate, evolve and...
So, Sharan, now we close the session.
Yes, thank
now
you.
the presentation, that will be a 7 minutes time, and we'll start with the Master of the Trauma, Dr. Tanna sir, first lecture.
Sir, can I ask one question, please?
Yes.
Your experience of using teriparatide and denosumab in elderly patients with osteoporotic fracture treatment.
Very good.
Do you use it regularly?
Regularly. In spite of a plate breakage, I have shown multiple times. I put the patient on teriparatide. I have put it on teriparatide.
How many months, sir?
18 months. 18 months, maybe 2 years. And I tell the patient beforehand, okay, do the surgery. Plate has broken, failed, but do the surgery. Patient says, I don't want surgery. And they come walking after 6 months, union. I've shown that case, distal femoral fracture.
The liver use of denosumab.
I will reframe your question.
Both together.
I think you put the question for osteoporosis.
Yeah.
I'll reframe your question. In a non-union setup, multiply operated upon in a young man, would you put them on 3 months of teriparatide? Yes.
Yes.
That is the question you want to ask.
Yeah.
But that is not recommended.
That is an off-label use. Off-label use.
Once given, it has to be completed for 24 months.
No. In a 25-year-old or 40-year-old, you don't have to.
Once it's united,
So, sir, off-label use, and this is an off-label indication for 3 months, 4 months. You cannot say that it cannot be continued. None of the Indian patients take for 24 months. I know that.
No,
Even
sorry.
my patients don't take for 24 months. sir.
My patients take it.
Post-operatively.
One second. We are not talking about the fracture treatment.
Yeah.
We are talking about osteoporosis treatment.
But you cannot stop teriparatide. If you give, you have to go. Is it
Now
supposed to
the
be-
majority is winning.
Is it supposed to be
The
used?
maximum safety. The
Amit,
maximum safety
Amit,
for
Amit,
teriparatide
Amit,
is 24 months.
Amit,
the
I
maximum safety.
Joshi sir, we'll have a separate session on this thing.
Sir, last question. Sir, do you use bisphosphonates after teriparatide after 18 to 24 months?
नहीं सर, अभी अपने को लेट हो रहा है.
I think we'll start with Tanna sir. Sir is waiting. Yes, sir.
No, I don't mind waiting more.
We'll discuss that in the night.
Oh. Junctional fractures, subtrochanteric. I'm only mentioning and only focusing on junctional fractures. At the junction of IT and the shaft fracture, which comminuted, I feel nail itself will not be able to hold the reduction. And you need an overkill nail and a plate. Always I'll do it for such sort of a community. This is a day one surgery, which I did that. Only nailing is unstable in such comminuted fractures. I am not talking about a two-part fracture where the nail has an excellent hold proximally and distally. I am not talking about those fractures. Like this, 5 months, surgeon did the nailing Hopefully this will heal up. This is the time, this is the one which is really, ultimately you can see here. This is the one for a treatment, nailing and plating, and it heals up. This is the one which you do it after 5 months or 4 months. Why not do it on day one? It may be an overkill, but I would like to treat the patient, give him the maximum chance. Like this fracture, day one, I'll augment this with the plate. Comminuted, not transverse junctional fractures are unstable in only nail. More non-union chance. Overkill is not a sin. This fracture, comminuted, severely porotic, nail it doesn't hold it so well. Again, I'll go ahead and do an overkill and get the patient move about immediately on day one. Now this fracture, you can see this is a wide medullary cavity. Probably it would have been healed up on day one by doing the augmentation plate. Can this ever heal up? You can see the wide medullary cavity here. Nail is only decorative, is not functional. So I feel just by doing a nailing and hoping that it will heal up is too much of a thought process and expectation. It should have been fixed on day one with the augmentation plate. Now here, long oblique fracture. Long oblique fracture again. This is the one which is not either you put in a circlage wire, put in a leg screw, but only like this is not all right. This went into non-union and the treatment was augmentation plate with the bone graft. Now this is the patient where the nail broke down. Again, this gives you a superb stability. So when in doubt, don't hesitate, do an overkill and do a double plating. Now I come to upper 1/3 and lower 2/3 and this fracture. This is the commonest non-union we see today because majority of the people think this nailing is enough. You can see this nailing, see this, hardly any hole, 2 screws is not going to really do a job. Again, treatment is nail and a plate. You can see this. This will go on moving one side to other side, destroying the bone. And you can see this, hardly there is any hold in the lower fragment. You can see the CT scan is moving up and here is a good hold, but lower down there is hardly any hold there. So this sort of a fracture, the option, some people talk about it, do a 4 screws distally. Now that also so much of a widening and the nail which is floating around may be helped by 4 screws distally. But I feel the distal femur nail is the one which has an excellent hold into the subchondrical bone. That's the one which can hold. But the antegrade nail somehow, here is the 3 screws in antegrade nail, this also didn't heal up, so ultimately we had to go there. Whether 3 screws or 4 screws antegrade nail, if you can put a subchondral, which is almost impossible to do it unless you can take a reamer without the guide wire and ream it ray all down. Instead of that, my choice is do a distal femur nail, and that's the one which has an excellent hold. You can do a distal femur nail which has an excellent hold. You can see I have done the femur nail and then I tried to see stability. Excellent stability is there. There is no movement with the distal femur nail, and this ended up into an excellent healing. This is because tip is subchondral, which is the best fixation. It cannot be done by 4 screws or 3 screws. So antegrade 4 screws may work, but I feel this is the one which is most important. And now this is the one which 4 screws, newer plates which have come up. And even this fracture, on day one I did the augmentation plate and the things have held up. This is again a distal femur nail. Surgeon did it. Again, went into non-union, had to be treated with the rigid fixation. On day one, augmentation plate could have done the job. And last I'll come to this distal tibias. Distal tibia, oblique fracture, it is unstable. Even the tibia fibula, both the plates are done. So you can see this. I have done the nailing. There is instability you can see. Now I did the plating of the fibula and still it is unstable. So if it is unstable, I augmented with the plate and the things have held up. So I feel in a distal tibia, long oblique or short oblique fractures, it is unstable and it should be treated with the augmentation plate. This is the one I feel is a treatment of choice for all the junctional fractures. Same thing is in the upper one-third. Again, you putting the nail, it may not be a good stability, so do a nail and a plate, things will be all right. So I feel that overkill may be at times too much, but I feel that overkill on day one, why not? What is the harm? At least in a doubtful fixation with doubtful instability. Thank you very much.
Sir, with the positive, अपने को खतरे कोरेशन में जाने का. So we can discuss one question only, and then those who are having some problems will discuss privately with sir.
Sir, I have to leave. I have told intertrochanteric fractures also should be having the combo technique, which you did not show. But
एक second, Mukhi Sahib, my subject is junctional fracture.
So for sake of time, we'll forget, no more questions.
अच्छा ठीक है.
Okay, point well taken. Yes, Shivashankar sir, start. Sir, Tanna sir is shifting towards your. आपने अंदर डाला, sir ने बाहर डाला plate.
Okay. There is.
Please start, sir.
Okay. Friends, good morning. The topic given to me is newer designs for distal femoral nailing. I have been using a lot of distal femoral nailing even before the newer designs came. This is one of such case way back in sometime in 2006. I have used this nail and patient had an excellent function for a C1 type of fracture, and this is at the time of implant removal. Then another lady, again a C1 type of fracture, again a close distal femoral nailing done. This is after the implants have been removed. You can see the scar and the patient had excellent function. But this article by Anderson made us to sit and think about the advantage of the nail. This says that the plate is such a rigid implant that hardly there is any subtle micro motion, and the fracture callus formation is too less, 0 millimeter at 12 weeks time. Whereas with a nail, it acts like a L0, and because of the micro motion, lot of callus is thin. At 3 months, it's 330 millimeter cube when compared to 0 with a plate. So, and another advantage of a nail is it's a global callus all around, not like in a plate, it's the opposite cortex. Underneath the plate, there is hardly any motion, so there is no callus forming underneath the plate. So, with the availability of newer designs, I have come back. In between 2006 to 2010, I was again doing all plating and other things. But again, I came back with the availability of newer implants. This is the nail I use, which is threaded bolts. It can be threaded within the plate, within the nail. So there is no necessity for putting a blocking screw. So this is one such case. I had done in 2016 this patient. This patient never came for follow-up. And once I sent one of my hospital staff to his home, he refused to come. I don't have any problem why I should come. But probably due to WIROC, he had a diabetic ulcer over one of the toe. He came just on 26, and you can see that the patient, the fracture is united, and the patient is able to walk comfortably without any problem. There is some osteoarthritis in the knee. Because of that, he is not able to squat fully, but at least he has got 120 degrees of knee motion. Another elderly lady, not elderly, a very FT lady. Again, I did a Supra Patellar nailing. It was a long oblique fracture, so I did a percutaneous wiring also in this case, and you can see at around 3 months' time the fracture has united, and this around 9 months the patient had a fairly good function. The patient is having, it was access was given everything in the preview room, but in spite of that it is not working here. Yeah. No, I have given in the preview room all the things I have done. So because of the varus in the knee and weight, she is walking the waddling gait. This is another, let's concentrate on the tibia, young adult, again comminuted fracture. So I did a supracondylar distal femoral nail with multi-lock in this case, but probably I heard too many lectures of Dr. Tanna, so overkill, I added a augmentation plate in this case. Yes, definitely in young patient, in comminuted fractures, where you cannot put a wire to get more stability, I think it's better to put a augmentation plate, and patient again at 4 months you can see full function of the knee, and at 7 months patient is walking. That car is coming constantly because made in India, that's one. Second thing is video taken inside the hospital, that will be little blur. So it is better to take under the sunlight. So that is the reason. See, what I want to tell is, when you use a nail, even such bad comminuted fracture also, when you put a nail properly, the nail, the medial side of the femur is a compression force, and the lateral side of the femur is a tensile force. So by putting a nail, you will be lateralizing the compressive forces. So even if there is a gap medially with a nail, there will not be any problem. But whereas with a plate, this gap medially will lead to failure. That's the reason why you have to add additional plate in such cases. But with a nail, a gap like this, I don't do anything. As long as alignment is good, the fracture heals without any problem, as you can see. Another case, this is Dr. Gadegone's case. Again, there is gap anteriorly also. Here also you can see that the fracture consolidates. Because of the biomechanical stability a nail can give. A segmental fracture femur, again a multi-lock femoral nailing has been used. Again a junctional fracture. The patient had an excellent outcome. C1 type of fracture. Again you can see that nailing has been done, and alignment is more important. Don't look at the fracture comminution. So I'll just go, no, don't put on that. Let me go to the next slide. Please. Let me go to the next slide. Those videos are not important. Patient anyway will be walking.
Sir, your time is up. Please wind up.
No, it's there. There is still 50 seconds. So another case. This is the last case I am showing probably. Yes, badly comminuted. This is a prize catch of Amit Ajgaonkar. You have intertrochanteric shaft fracture. Then you can see that distal femoral nail with a proximal plate has been done. This is the type of nail he uses, which cannot be threaded within the nail. And the patient had a, yes, please. Patient had an excellent outcome with full function. Yes, Bhaiya, kya kar rahe? Tambi. They have no control. You have a control. No, this access video. They have saved it. In spite of that, it is doing here. Yeah. This is badly comminuted fracture. Again, very old 2007 picture. You can see that with a nail, with such a medial gap also, the fracture urates and the patient gets an excellent, probably with a plate, probably I would have failed. Very badly comminuted fracture. Again, I don't mind using these nails and to get good union around the implant. So, to conclude, if a fracture like this comes, the only thing which comes to my mind is putting a nail. Thank you very much.
So those who are willing to ask him the question, they can ask privately because he is a master nailer. So you will get a tips and trick. Not in public because it's short of time.
Because his answers may not be agreeable to the other faculty.
That is more important.
Dr. Chandak sir, your time.
Respected chairpersons and my dear friends, the most important judgment in nailing procedure is to know an exact entry point. Once you have a good entry point obtained in a complex fracture, then the job is done easily. There are three basic entry points: lateral trochanter, tip of trochanter, and piriformis fossa. As you can see on the diagram, the tip of trochanter, piriformis fossa, and the trochanteric fossa. The lateral trochanter entry in a pediatric is required in adolescent age group as described by the author. The femoral entry portals, there are two important entry portals. Lateral trochanter entry portal, the problems are it may result in lateralization of nail, varus malreduction, and comminution of the greater trochanter. The piriformis, the problems are more challenging in obese, More soft tissue dissection may result in fracture of neck of femur and may hamper proximal femoral blood flow. So these are the problem with these two entry points. So this is what depends what implant you are going to choose. A nail which is straight or a nail with a lateral bend, and then you choose the entry point. The authors brought attention to this very important fact. The piriformis fossa is the site of insertion of the piriformis tendon and represents a small shallow depression located on the medial part of the trochanter, and the trochanteric fossa is the posterior hollow depression. So this was misreported in initial lot of literature. So this is the anatomical consideration. Look at the trochanteric fossa, look at the piriformis fossa. The trochanteric entry point, the entrance, if it is quite anterior, can lead to blowout. So you have to determine the exact entry point where you want to put your nail. This was brought to the notice by Moin that a straight nail has an entry which is piriformis, and a nail with a bend has a trochanteric entry. As you can see, the trochanteric entry with the A2FN can give a equally good result. Now these are the images as we see on lateral view. Just concentrate on them. The trochanteric fossa entry as it looks, this lateral image would be here. This would be the medial entry point. This would be a owl which has slipped posteriorly, and just identify whether this is right. So piriformis entry would something look like this on a lateral entry. On an AP projection also you can have an indirect indication of lateral projection. If your spike is dipping too much, you are more posterior. If it is dipping this much, around 3 to 4 millimeter, you are at the right entry point. This is your just prediction. Once you have an entry point and you have taken a guide pin, then you want to preserve that entry portal. You don't want to miss it. What you can have is a split sleeve, and which is serrated. You can just hammer it in, and then you can exchange the guide pin with the guide wire. This is how that can be done to preserve the portal. This is what usually happens, the entry portal for most of the femoral nails. What we are worried in an adolescent pediatric age group is not to damage the vascular flow. For ease of getting ideal entry point, decide the table position. What I would like to do is to turn the patient a bit and give a banana adducted position. And entry through a greater trochanter is easier if trochanter is wide and you are taking an entry with the desired nail. These are the problems of the trochanteric entry point. And many times you may lead to a subtle varus, and therefore a medial entry is nowadays more resorted to. A lateral entry point portal is useful in an obese individual. This is the anatomy of the greater trochanter, and the bald spot was brought to the notice, and this is that spot with the lateral bend entry nail. The anatomical site, entry through piriformis fossa, is what nowadays more resorted to, because it leads to less amount of varus, and we have to avoid this situation where the nail is thrust through the fracture fossa. In a subtrochanteric fracture, if the entry is more medial, that does not lead to varus. In subtrochanteric fractures, nowadays the more preferred part is more medial entry. When you take the entry in line with the femoral shaft, in line with the entry point, what you will have to do, pass your scissors, split the muscle, and then go to the desired spot to get a good entry. So this is the entry point. Tough or porotic bone, two different situations. In a tough bone it is difficult, and then your awl has to be very sharp. What I would prefer is a AO awl. Give a stab incision where you prefer to give it. If you are more anterior or posterior, that becomes difficult for the nail to pass. Take an entry point with a guide pin, and
Sir,
once
please
that
summarize.
is fine, if that is fine, just go ahead with the entry point. There are certain variations in just 2-3 slides. Variations in trochanter, as has been brought out, anterior leaning trochanter, posterior leaning trochanter, and a trochanter which is well centered. So be aware of all these variations, and then obtain your entry point. Determine the instrument what you are going to use. The best I like to use is the AO owl, which is very effective in getting a good entry point. And read all these Siam images perfectly. Don't get a portal which is oblong, get a right circular entry, and you can choose your entry point and make a good entry point. A good entry point makes all the nailing procedure quite easy for you. Thank you. Thank you so much.
Thank you, sir. Quickly, we'll have. Yes, just tell us the final points of Supra Patellar Nailing.
Yes. So time is over, therefore we will finish within 5 minutes. No, actually. So this is suprapatellar nailing, and this is proximal and distal tibia. You can see similarities between proximal and distal tibia. Quadriceps is the deforming force in proximal tibia. Fibula is the deforming force in distal tibia. And these are all, what is more important in proximal tibia is the entry point. Center position in nail is important in the distal tibia. So proximal and distal tibia, what is the preferred treatment is the standard treatment is plate. But with the new designs, it is why it is because of plate. Nail of older design gives instability, technically demanding and a high malunion rate. Is it a work to advise nailing in extreme tibial fracture? Yes. With these multiple locking nails and new designs, it is possible with the use of a polar screw. And these are all predictable deformities, and we can all nullify this and can be reduced in semi-extended position with suprapatellar approach. And this is the suprapatellar approach. Reduction devices, reduction clamps, use of plates, and these are all example reduction and augmentation tool, and you can do a plating very well nicely. So these are all you can use external fixator, blocking pins to reduce the canal and to position the nail in a proper position. Using blocking screw minimally invasive, prevent adjuvant, prevent valgus, varus, flexion and extension. And this entry point is very, very crucial. That is lateral to the tibial spine. This is most important in APN lateral. And this is the suprapatellar approach in a semi-extended position. These are all operative steps. And you can see a soft tissue issues, stretching the limits of suprapatellar nail by bypassing the surgery. And these are all segmental fracture, proximal tibia. You can have a segmental fracture, proximal tibia can be well treated by a minimally invasive treatment. Current indication for nailing for distal tibial fracture, it is near about 30 mm plafond, and you can use a blocking screw to centralize the nail. And this is how you have to centralize the nail by putting a blocking screws. So suprapatellar approach, semi-extended position, you can see here, you can do these are all operative steps. And intramedullary nail with adjoint nail or plate, you can use it. So in conclusion, suprapatellar approach, shorter fluoroscopy time, less knee pain, better knee function, more accurate reduction, no increased risk of post-operative complication. And take-home message last, that is the question everybody asks, cartilage damage is a theoretical possibility. Do the suprapatellar nail, and you will find that it is one of the most useful method in the arena of orthopedic practice. Thank you very much.
Thank you, sir. I thank the chairman, Dr. Prakash Sankhla, and the esteemed panelist, Dr. Tanna sir, Mukhi sir, who was there, and Professor Shivashankar sir. Thank you, Gadegone sir, and thank you, Hall in charge, Dr. Chasnath.
Thank you, everyone. So next we have success of infection in pediatric population. So I request the chairpersons, respected Dr. Atul Bhaskar sir and Dr. Viraj Singade sir, to please take the dais. We have already given our 2 minutes to the earlier session. So, Dr. Saifuddin Naqvi. Sir, yeah. So, console, start the intro slide, please. Intro slide.
So good morning, everybody. This is the session on pediatric infections. So I welcome my panel. There are Dr. Viraj Singade, Dr. Swapnil Kenny, Taral, Maulan from Ahmedabad, and myself. And we'll try and cover in a short while, in a short session, the success in infections. Next slide, please. I can click it from here now. So what do we mean by day one success? One is battling infections is a long process. No infection resolves in one day. It's a ticking time bomb. So delay can be deadly, but a pragmatic plan, appropriate imaging, and a team approach on day one can save many joints. So that's why I think the day one success is not success on day one, but actually the plan you make on day one which will lead to a long-term success. Okay. So I think my talk is first, so can you load the first talk? Yes, sir. So my talk is on neonatal infections and the need for speed. And I think this is one aspect of infection in children where really time is of essence. And if you are delay in neonatal infection, it can lead to devastating complications. And always respect the tissue biology. I think in neonates, don't try and be aggressive because there is great remodeling ability as well of the bone. So just giving an example, this is a 20-day-old child who presented to the pediatrician with the pain and swelling around the left shoulder. The restricted range of motion, when we saw the child, the mild fever, but the child and the parents didn't want any surgery, so he was on antibiotics. The swelling increased. By the time they came to us, there was an abscess there. We drained the pus at around 3 weeks later, and you can see the destruction already at 6 weeks. So the rapid destruction of the epiphysis, and we know that from the biology, there is a vascular supply from the metaphysis to the epiphysis, which can lead to rapid osteomyelitis and septic arthritis in a neonate. And often, by the time the child presents, the signs are not apparent, and hence the need for speed. So damage is always done by the time the child comes to us. So if this is more than 48 to 72 hours, already the infection has set in into the metaphysis. The signs are very limited in this age group. Sometime in an overt case, you will find, in septicemia, you will find signs of infection in the skin as well as in the tissues. But the classical sign is refusal of joint movements. The child, if you examine the child, he will not move the leg. So what we call pseudo-paralysis. And I'll illustrate by this, there are a couple of videos here. So this child, you can see, is not moving the right leg. This child, which is for recently, is not moving the left upper limb. And actually, you were diagnosed as a Erb's palsy, and there was no movement of the hand. But we got a scan done, and the scan showed infection in the shoulder as well as the leg. Even the left leg is not moving. And this child underwent arthrotomy of the shoulder as well as the knee, and then made a full recovery. This is the image in the PICU. The child was on a PICC line and 6 weeks of IV antibiotics. So this is another example of a child who presented with femur infection. You can see the amount of pus pouring in. At 1 year, the femur is completely remodeled. So if you treat the infection very well early on and just stabilize the joint and the bone, remodeling is on your side and usually the bone will heal. Another child with hip infection, we done arthrotomy in the acute stage. It grew Klebsiella, and you can see the cavity completely resolved in 6 months. So early intervention in a neonate will give very good results. Always have a very high index of suspicion. And any child with an abscess or a cellulitis, don't refer to the pediatric surgeon. They will drain the abscess and leave the bone. Always think of osteomyelitis or septic arthritis in the presence of cellulitis. So a few take-home messages: don't let the sun set on an infection. You see a child overnight with an infection, do it in the night. Don't wait for the next day. So don't miss early signs. Try and liaise with your colleagues, pediatric colleagues, microbiologists, anesthetists to offer early and emergent care. Operate splint, IV antibiotics. Maybe you can put a PICC line, and reconstruction in late cases, as we'll see from our other panels. Thank you very much. So I'll invite, I think Dr. Viraj is next from Nagpur.
So as Atul has mentioned very well that in neonate, if there is a decreased movement of the limb, I think the infection is a first priority and first possibilities one should always remember in mind. Now we come to the early childhood. So what are the different situations, right? So the first situation is like this: when the child is presenting with limp, right? But there is no pain and no fever. So when there is no pain, there is no fever, it could be just simply reactive synovitis or the transient synovitis. This girl had no pain, no fever, just observed, and then you can see the subsequent improvement in the gait. No analgesics, no antibiotics at 12 days and then at 3 weeks, right? So she recovered fully. So the situation number 1 is when there is no pain, no fever and only limp. So don't overkill, don't think that it is an infection. That is situation number 1. So if there is decrease or the painful movement of the limb and then associated with the fever, you should always and always suspect that there is a possibility of infection, and that should be your first possibility in mind. You can just do the clinical examination. Most of the time you are able to diagnose. X-ray may not be too helpful, but mandatory, you have to take the X-rays. Sonography, still people believe that sonography may help, but again MRI is the most important investigation to confirm your diagnosis of infection. And of course the blood investigations, they are going to add on that, and you have the pain, fever and decreased movement of the limb and then associated supplemented parameters, it is infection and nothing else. So what should be the next line of management? Are you going to still give only antibiotics and not preferring surgery? The answer is no, because if you just give the only antibiotics, it is going to cause a more chance of damage to the joint, and that is how, because the antibiotics which you are going to push, they may not reach to the joint because of the pressure in the joint. So you have to drain the joint, because that will give you the chance to get the culture, what are the microorganisms which are going, and it will give the chance for the antibiotics to reach to the site also. So just joint wash is very, very important. Being a surgeon, don't hesitate and go ahead and give the joint wash. How long you are going to give the IV antibiotics? The antibiotics has to be IV only, and how long? Usually 3 weeks to 4 weeks is sufficient time, right? Now we are talking about the third situation. First, synovitis, I explained you, it recovers. Second situation, when there is a pain and fever, it is an infection. Now there are certain surprises. Now this girl, she had just a mild grade of fever and she had involvement of both of the hip joint. So she was suspected that she could have just arthritis, right? But when it is a sudden onset, when it is acute onset, it can't be just arthritis. It has to be infection, even though mild grade fever. And the MRI, it confirmed that there is definitely a significant amount of the effusion which was there in both the joints. So I told the patient that it is an infection and nothing else. And when we opened both the joints, there was a pool of pus in both the joints. So how do we manage? After surgery, we give the usually traction so that they don't land up with the fibrosis and amount of the deformity which is there. And then we give the 3 weeks of the IV antibiotics, right? And many times we give just the traction, so that the child is not getting the deformity, and we mobilize on the traction, right? That is there. And this is a 6-month and then 3-year follow-up of the same girl. So if I would have missed this, and if this girl would have been treated on the line of rheumatoid, I think the mess would have happened and both the hip joints would have gone, right? So that is the case, scenario number 3. Now we come to the scenario number 4. There are many patients, there are many children who are on some medications. Now this girl, she was on medications for skin disorders. She has some arthritis, not arthritis, she had some kind of that eczema like situation, and then she was on prolonged medications on that. So she don't have much fever. Again, the low grade fever was there. And when we did the MRI, there was an infection. This was the intra pus. You can see these patients, they have very rare kind of infection. This girl had a Studzery. I don't know why that was the name of the organ was Studzery. Maybe Vinoti may be knowing, she's in medical college. So we have drained it and ultimately she recovered. So if we would have missed again, this would have been again the disaster in this child. Now, if you see the 9-year female, now this girl again was on long-term steroids and other medication for some systemic cause. And then suddenly she developed the hip pain, but there was no fever. Absolutely no fever. Parents were saying, no, doctor sahab, bukhar aata hi nahi hai. We did the MRI and there was a gross effusion. I said, this is infection and nothing else. We have to open the joint. See the pain which was there. So if there is pain, even if though there is no fever, you should suspect the infection. And let me tell you, and see, this is the intra picture which is. So this is scenario number 4, right? So even if there is no fever and if you are clinically suspecting there is no harm, go ahead and open the joint. The wash was given and this is a further follow-up. And I think this girl had a good range of movement as well. Right? Now, why I'm telling you it is important, because if you look at this girl had an infection and she was managed only with the IV antibiotics. And this has happened. The whole femur as well as the neck of the femur, the femoral head and neck of the femur has gone. This could have been easily prevented if surgeon would have acted at the time, right? And that is why when you are clinically suspecting it, so just go ahead and do the wash to the joint. So to conclude, infection in joints in a pediatric age group, it's a clinical diagnosis. MRI is definitely helpful. Whenever you have doubt, go ahead and give the wash. IV antibiotics are very important. And we give some traction to the most of the patients so that to prevent the contracture. And of course, what is important is long-term follow-up. Thank you. Thank you for your kind attention.
Thank you, Virat sir. Questions will take later at the end. And next, I invite Dr. Taral Nagda sir for acute osteomyelitis in children, a team approach.
So what I'm going to do is actually take you through this real life encounter and show you how actually I would manage a case of acute osteomyelitis. So there is literature and literature, and the problem about literature is it's confusing and contradicting. And that's why it's better to listen to a wise man who has seen all of it over a period of time. So I'll just illustrate the whole process through this case, how an evidence and eminence-based approach helps us managing this child. So this child presented with fever to a pediatrician, and as always happens, a pediatrician, pain in both lower limbs and fever, infection doesn't come to their mind. The diagnosis was viral myositis. And then they give antibiotics for a viral myositis and rest to the child. And when things go out of order, the child started feeling a little dizzy, toxic, then they refer to a hospital with a diagnosis of viral myositis. So this is first thing which should be prevented. We must educate our pediatrician. Whenever there is a bone complaint, I think they should remember an orthopedic surgeon and not a rheumatologist. So this is how this child presented to us. The first thing is, what lab investigations will you send as the child is admitted? So first thing which we often forget, everyone remembers CBC, ESR and CRP, but we forget blood culture. And blood culture should be done before starting an antibiotic or before changing an antibiotic. So first thing you will do is take a peak line and send blood culture. C-reactive proteins should be sent. You should send for titer. It is not diagnostic, but it helps in managing the patient. Serum procalcitonin is in fashion, but it has been proven that it really does not help either in diagnosis or managing the patient. So this is what we sent. We get leukocytosis, WBC high, high ESR, very high CRP, normal X-ray and ultrasound showing right hip effusion. But in this case, left hip did not show any effusion. Patient had bilateral lower limb pain. So as far as septic arthritis was concerned, the Cocker's criteria were met with, and obviously this was a case of septic arthritis with ultrasound proving that. What we did, you have to have an IV access for long-term antibiotic treatment. Blood culture, it's very important to look at the limbs for swelling for DVT, because if you have high temperature, a child admitted to ICU, associated other problems, or MRSA, these children can have associated DVT, and this can be limb-threatening or life-threatening, and hence has to be recognized and investigated if present. What is the first antibiotic you will start? That will depend on the setting, whether this is community-based, hospital-based, whether the patient has already been treated with antibiotics, and what was the response to that. But generally, you should start an antibiotic which will act against Staphylococcus aureus in a setting like that. So we started the child on IV amoxicillin and clavulanic acid. It has been proven now. Previously, we used to think that starting an antibiotic will decrease the culture yield. But there are enough studies to prove that if you give antibiotics and then get a culture from the bone or the joint, it does not decrease the yield. It's perfectly okay to start with antibiotic if the child is toxic, and then during the surgery, collect your sample for the culture. What imaging to do? Of course, plain X-ray will you do, but ultrasound by itself is not sufficient, and there are a lot of reports to prove that magnetic resonance imaging is the study of choice if possible, if affordable and available. So we did MRI in this patient, and I want to prove this point that of course it showed septic arthritis on the right side, but it also picked up osteomyelitis on the left side, which would not be picked up on X-ray, on ultrasound, or any other investigation because the periosteum was not yet broken. So this was 1:20 at night. When should you treat this? You should treat this as early as possible because osteocytes are dying every moment. And what was done was, of course, we aspirated the hip as told by Viraj, got pus, and because we got pus, we did arthrotomy and debridement and got the pus out. What do we do for the bone? Under image intensifier, we made a small opening. Should we make a window? If you make a window, should it be square or round? What is in literature is you can make a drill holes, 2 drill holes with 2 millimeter of drill bit. They are sufficient to decrease the pressure and drain out the cavity if it's a liquid pus. However, if it's a solidified pus, or if you are suspecting a diagnosis like a chronic granulomatous lesion, I would make a window and drain out water and release whatever I can. Now, when you drain or debride, should you put local antibiotic delivery system? And I'm looking at Sandeep Vaidya and Patwardhan, both which are sitting next to each other. People are putting stimulant and other agents acutely, but there is no evidence for that at present. Another problem is when you put an antibiotic loaded system, you don't have organism, you really don't know which antibiotic works. So I like Mandaragash's approach where he does a second look operation after getting the culture done to put the cement if required, if antibiotic response is not there. So this patient had gram-positive cocci. We continued the antibiotics. Of course, you have to rest the part because there is high rate of pathological fracture. If you don't rest it, here it was more convenient to put him on traction, and then weight bearing was started after 3 weeks with support. So this patient had confirmed acute hematogenous osteomyelitis, but if you have suspected where you don't get anything on culture, you'll have to start antibiotic by referring to a ID specialist if available. If not available in your setup, many of them are available for online consultation and guidance, and I'm sure that you must take help of them. So how long to continue antibiotics? You should have a response-based duration of antibiotics. So if you have low risk, social situation reliable, short case, especially if CRP comes down to base early. But if there is high risk, for example, this child, osteomyelitis with septic arthritis, MRSA, your antibiotic will be for a longer duration. So in this child, we give 4 weeks of IV antibiotics. Doesn't mean that child has to be admitted to the hospital for 4 weeks. The child was admitted for 5 days. Once his symptoms subsided, fever went, he went home, and then he was given home-based antibiotic treatment. CRP fell down by around 4 weeks, so that's the time we converted into oral antibiotics, which were appropriate. So what we've learned from this case is that initial clinical assessment, references and investigations are important. IV access, CBC with CRP and blood culture. Start with an empirical appropriate antibiotic. You must do appropriate investigation, which my choice would be MRI. Decompress and send for smear culture and sensitivity. Monitor clinically and with CRP, and then you should choose short or long-term antibiotic program as per the need. Thank you very much.
Thank you, sir. And after all this infection, next we have Dr. Swapnil Kenny, who will talk of the infection mimickers and role of imaging.
Thank you very much, respected chairpersons. My predecessors and senior predecessors on this panel have very succinctly elucidated about treating osteomyelitis, the acute aspect. But things are not always as clear. There are always dilemmas and controversies. And osteomyelitis is one such condition wherein you may have multiple dilemmas, multiple controversies, and that is why the role of imaging is extremely important. So, as I said, that there are many other conditions which mimic infection. As my panel said, that we do see osteomyelitis in clinical practice. We do conventional radiographs, we do ultrasound because it is fast and non-invasive. We can also do certain procedures like ultrasound guided aspiration. MRI, as everybody said, is superior, sensitive, specific, and is considered as the gold standard. And more than that, imaging can actually help you to differentiate between what is infection and what is not infection. So the mimickers of infection could be vascular disorders, traumatic disorders, inflammatory conditions, and certain tumors. Now let's look at some day-to-day situations. Many a times you get X-rays, and these are the typical 4 types of X-rays which you see. There are certain peculiar patterns on an X-ray in a bone. There are lytic lesions, there are periosteal reactions, and many a time there are lesions at multiple locations. Let's look at this 3-month-old child with pain in the knee. Imaging is showing a soft tissue shadow around the tibia, and there is a little bit of a periosteal irregularity. Do an ultrasound, and this actually picks up a subperiosteal fluid collection with an abscess. This was aspirated and treated with antibiotics, and it was not drained, and the child ended up doing well. This child, lytic lesion in the greater tuberosity area and just below it, and an MRI very clearly delineates a hypointense cavity with a rim of discrete peripheral zone of hyperintensity, what is called as the penumbra sign, which is a sign of infection and has a very high specificity and sensitivity to diagnose osteomyelitis. Once you have this, you can put in a needle, aspirate, you can get a culture, and then you can start on empirical antibiotics. 16-year-old girl with acute onset pain in the left leg with this kind of a periosteal reaction. The differential is an infection, a tumor, or maybe something else. A MRI picks up a stress fracture, treated conservatively, of course. An X-ray with a permeative pattern in a young child, again, and an MRI again picks up some amount of cortical destruction with fluid collection and abscess, which essentially is an infection and not a tumor. This 18-year-old girl with non-specific shoulder pain had these lytic lesions in the proximal humerus, and you often wonder what this is. And an MRI actually shows that this is a tumor which is penetrating the epiphyseal plate and getting into the epiphysis from the metaphysis. Again, a 10-year-old girl with sickle cell anemia with shoulder pain, and you often wonder whether this is a vascular problem or an infection. And an MRI picks up a soft tissue abscess as well as medullary changes inside the bone. And this is how you pick up a infection, again treated conservatively. A 17-year-old boy with a permeative pattern on X-ray. A CT shows an endosteal scalloping with a periosteal reaction. And an MRI shows an expansile destructive lesion in the proximal tibia. A iliac bone lytic lesion seen on a CT scan with peripheral enhancement tells us that this is a Brody's abscess and needs to be managed conservatively. A 13-year-old boy with a periosteal reaction, an MRI shows a permeative pattern, so you're still not sure whether it's an infection or a tumor. But a CT-guided biopsy helps establish the diagnosis of osteomyelitis. A child with multifocal involvement, sclerosis, hyperosteosis. An MRI shows that there are changes in the bone marrow and soft tissue edema, and a technetium scan actually shows that there are multiple lesions at various levels in the skeletal system. Biopsy and culture negative, and this was a chronic recurrent multifocal osteomyelitis. So what to do when? Acute osteomyelitis, X-ray has a low sensitivity. Ultrasound, you can pick up soft tissues, you can do an ultrasound guided biopsy. MRI is highly sensitive and the investigation of choice. Septic arthritis, ultrasound is good because it can pick up a lot of stuff and help you do a biopsy. MRI definitely gold standard, X-ray not much to do. A Brody's abscess, X-rays yes, but a CT scan is a good investigation because it can pick up a sclerotic rim, and of course an MRI is a good option. And chronic osteomyelitis, again a CT is not really of help, but an X-ray and an MRI is probably the investigation of choice. So the imaging strategy should be in acute osteomyelitis, if the conventional imaging is normal, an ultrasound or an MRI needs to be done. If there are signs of osteomyelitis, then MRI with CT combined can help us to plan our strategy. Chronic osteomyelitis, conventional imaging if normal, MRI. Signs of osteomyelitis, CT and MRI. Multiple locations, you can do a PET scan. So to summarize, there is always a dilemma whether CT or MRI, but believe me, both these investigations are collaborative, cohabitative and cooperative. Thank you very much.
Thank you, Dr. Swapnil. And now for the last talk of the session, we talk about dealing with chronic osteomyelitis, classification and principles of treatment by Dr. Maulin Shah.
So good morning all and thanks the organizers for bringing me here. Now chronic osteomyelitis, why we need to classify? Because we know that there is more than often some disparity between what the surgeons explain and what the patients get, and the disparity always brings in conflicts. So we all should know a good classification, a reliable classification, and I've searched the literature and found that this has been a radiologic classification which has been found to be reliable, published in JPO 2009, and they divided chronic osteomyelitis in 4 types: a Brody's type, which my colleague presented, a sequestrum involucrum type, a sclerotic type, and they have found that there is some unclassifiable osteomyelitis. Furthermore, the sequestrum and involucrum type had 4 subtypes. I'll explain to you with figures. So type 1 is the localized cortical, where the sequestrum does not alter the integrity of bone. One with structural involucrum, where the sequestrum will gradually get resorbed. The other one is without structural involucrum, that will hamper the bone integrity and you need to treat them. And the last one is a sclerotic involucrum, which usually ends up with a chronic discharging sinus. Unfortunately, this classification is based only on X-ray and doesn't guide to the treatment. And the main principle of treatment is you should not rely, or there is minimal role of antibiotics in treating chronic osteomyelitis. Disease clearance is the mainstay. So how we have approached chronic osteomyelitis in our practice, we rely on 4 factors, and those are whether there is presence of active infection or not, whether there is sequestrum present or not, bone integrity is there or not, and whether there is any associated deformity. Sequestrum can be 2 types, whether it is incorporating or non-incorporating. If infection is active, you clear it. If sequestrum is incorporating, you leave it. If it is non-incorporating, you remove it. Bone integrity is not, that you provide it. And finally, if there is associated deformity, you correct it. So this is in a nutshell how we deal, and I'll show you with case example how we apply these principles. So this young girl who was operated by a pediatric surgeon with pus discharging sinus, they have received antibiotics for 2 months, and MRI and X-ray is showing that there is presence of chronic infection. Now you see these factors. There is active infection, there is no sequestrum, bone integrity is okay, and there is no deformity. So you need to just clear the infection, and we did intramedullary decompression with the giggly saw wire technique. There is 1 month follow-up, there is 6 months follow-up. Once the infection has been taken out, the gradually involucrum will build on, and there is 6 years follow-up, and that child did well. So here the problem was only infection, and you have to clear it. Now this young girl, about 6 months old, who had a fell followed by abscess formation, again pediatric surgeon drained it, and the pus kept on coming, and then he got an X-ray and the patient was referred to us. Now you all can see that there is active infection. You can see the sequestrum is there, is probably incorporating at one of the ends. Bone integrity looks okay, and associated deformity is not appeared yet. So what we did, we opened it, we cleared whatever infection was there, we checked the sequestrum, it was glued at the distal end, and it was not completely separated. So I placed stimulant beads, and you see the response. Gradually the infection stopped, wound got cleared, the sequestrum got separated, but now there is a good involucrum over it, and in 3 months time the involucrum organized, the bone got absorbed, the 6 months and 2 years follow-up. So the whole ulna came back well. So here we just clear the infection and we preserve the incorporating sequestrum. Coming to this case, 4-year-old boy with continuous discharge after debridement done before 3 months at other center, And this is the MRI picture and the X-ray. And at 3 months, child presented with this. And now if you evaluate this X-ray and factorize the problem, there is some infection. Sequestrum is there, which is non-incorporating. It's not affecting the integrity. And there was associated deformity, the mild procurvatum deformity. So what we did, we removed the sequestrum at stage 1. The infection was subsided. Child sustained a stress fracture twice, and so we corrected the deformity with intramedullary nail in the stage 2. And this is a 5-year follow-up. So here we dealt with the deformity, infection, and non-incorporating sequestrum. Now this 6-year-old boy with 5 previous surgery, you can see these sequestrum, which is not incorporating, and there is active infection, and bone integrity would be a problem. So you have to deal with all the 3 things. What we did, we placed an distal corticotomy, placed the frame, and then transported, and we grafted it once it got docked, and this 5 years follow-up. So of course this child had undergone many surgeries in between, but that was a good outcome at the end. Let me take this final case with 10-year-old boy with infantile osteomyelitis and 5 previous surgeries referred from UK. And there is a apparent cubitus varus. And if you look at the X-ray, there is complete loss of ulna. There is subtotal loss of ulna, and there was a question how we can reconstruct it, whether we have to do one single bone forearm. But you look at the X-ray closely and see there is no active infection because there is a cleared out disease. There is sequestrum. No sequestrum, but bone integrity and associated radial deformity is the problem. So what we did, we corrected the radial deformity with osteotomy. We placed the fibula interposition, fixed it with a nail, placed corticocancellous graft at the top and bottom end, and provided a monolateral fixator to give some rotational stability and splinted it. And this gradually went on healing, and there's 1-year follow-up of the same boy. So in conclusion, management of chronic osteomyelitis is challenging, but principle of management is to factorize the problem and address it. Thank you very much.
Thank you, Maulin. And we have some time for questions. So any questions, you can please take the mic.
So my question is to Atul. Atul, how do you decide the type of antibiotics in NICU infections?
Comes, then we obviously switch over to the antibiotics. So broad spectrum antibiotics we decide normally with the pediatricians or the ID specialists. So I don't do it on my own because the dosing is very important. You don't give a conventional dose. You have to give high dosing, and then you look at the systemic response to it. So I think broad spectrum antibiotics, which include gram negative, gram positive, then decide the culture. So once the culture comes, you obviously switch the antibiotic.
So one difference I would like to say between treating a child and neonate. In child, we always want to give short-term antibiotics and convert to oral. In neonate, it's very difficult to give oral antibiotics because you are never sure about the intake. So neonates would receive IV antibiotics for as long as it is required.
A question for Taral. Would you continue IV antibiotics in acute osteomyelitis till the CRP normalizes? There's a paper from Australia where they found when these more than 50% reduction in CRP, they switch to oral antibiotics.
So not normalizes.
Yeah.
Till after a rapid fall. So you sell your shares, you know, when there is a rapid fall in the price or when there is a rapid fall in CRP, that is the time to switch over. But you know that it's practice. See what is mentioned in books and what actually happens in a given situation when you are treating a patient. It's completely different. Many times it so happens that child is clinically improving, but CRP is not coming down. Sometimes CRP comes down rapidly, but child still is cranky, has fever. So you have to balance, and finally, you know, you will have to decide. But I would say that child has to be clinically all right, and CRP should fall at least to below 20. You know? So if the initial CRP was 120, it came down to 60, I will not switch on to an oral antibiotics. Because the quality of oral antibiotics and the compliance, you know, we are really not sure in our country.
to do the CRP, within 2 days after surgery, because that response of the surgical insult itself will increase the CRP. So do it at 1 week, and that will give you a trend. So that is also important when to do the CRP.
And from the same lab.
Correct, correct. So the timing of the CRP is also important.
All the faculty is that if you have a young child with a multiple bone pain with a normal CRP and child is non-toxic, but the X-ray shows small osteolytic lesions, how do you approach that?
So one of the differentials is...
what could be possibilities and what should people do?
One of the possibilities is metabolic bone disease, like parathyroid adenoma may give you multiple brown tumor, that is one. And a multifocal infection like tuberculosis infection can also present with normal CRP. So there's two things coming to my mind.
Yes, Sandeep, I think, yeah.
I think the treatment of osteomyelitis today is a team approach. Essentially, you need to involve an infectious disease specialist. Your role is to, one, as a surgeon, try and get a tissue diagnosis per se, not antibiotics. Giving antibiotics or deciding which ones are probably not your role. But definitely when there are multiple lesions and if one of them is amenable to a biopsy or an aspiration, then I would definitely do that and also try and rule out if there is something else. Of course, there is going to be a battery of clinical investigations, but my role would be very, very clear to differentiate it from an infection from some other condition, which may not be under my
two diagnoses which come to my mind. Of course, Pauline's wife is an endocrinologist, so he thought of metabolic first. And it's good you are remembering her. But two diagnoses which are very important. One is malignancy and second is chronic multifocal osteomyelitis. The investigation of choice today is whole body MRI. When we used to laugh at people who would advise whole body MRI, but it's a done investigation today. And for many conditions where you have a lytic lesion in TB, I don't know if we are showing that case because we are running short of time, but when you have symptoms and signs which are less proportionate to the radiological changes, and when you have seasonal pain, which is and multifocal locations, non-infective osteoarthritis is a diagnosis.
That was what I was coming to. That
but you need to do a biopsy.
I had children who had been treated as osteomyelitis because the treatment of it's an inflammatory pathology of bone which is multifocal, and you don't need to do a biopsy unless you know that this exists. And my preference is to do a nuclear scan. If it shows hotspots and your labs are okay and there is no leukemia or metabolic bone disease, then steroid is what works for a short course to take care of the inflammation. Whereas in infections, you would never give steroids initially, unless there is toxemia, of course.
So there are two things during discussions coming to my mind. There is one child from neuroblastoma. He had multiple lytic lesions, and there you cannot give steroid. That's a very grave diagnosis. Another is eosinophilic granuloma. So there you have a whole body. Yeah.
I think the important thing what Swapnil said, you must establish a diagnosis. Either radiological or do a tissue biopsy. Because parents, and I think at the end of the day, they will want a diagnosis, whether it's by exclusion or by criteria. So I think one has to do a tissue diagnosis.
And as Sandeep mentioned already that the child is not sick, so that itself, the clinical judgment has to be there that it can't be infection. It has to be something else.
In the post-operative period, if the child is not settling clinically, what is the imaging modality of choice? Because, MRI, it is very difficult to differentiate whether these are the post-operative changes or changes associated with a residual infection. So, how would you go about it?
So, two things. One is the reason why patient doesn't settle. One is a complete clearance of infection has not been done. For example, there is a child with a septic arthritis where a concomitant metaphyseal osteomyelitis is missed. Okay, that is the reason, one of the reasons wherein definitely an MRI will help you. Second is a very fulminant infection where you have to be patient and wait for the culture. And sometimes, despite all this and continuing on antibiotics, it still doesn't settle down. And there is no other clinical sign of infection, but patient has a raised ESR, CRP and fever continues. So that is where one has to be patient and have faith in the antibiotic regime.
Problem is, can you rely on the MRI? Because I have seen cases where the child has settled clinically, but the pediatrician as a routine get a repeat MRI done on day 5, and it shows, collection and,
so MRI
in fact,
always,
aggravation from the pre-op picture. So, what do you rely on? If not MRI, then what?
So if the child is settled, then I think it is going to be basically your clinical judgment. The question comes when the child doesn't settle. That is where, the problem really arises. So we all know that MRI follows the clinical picture, and MRI may show a very ghastly picture when the child is actually settling down.
So here the sequence has gone wrong. See, MRI is here to answer clinical questions. You don't have clinical examination to answer questions which are raised by MRI.
Extravagance-based practice.
But there are situations where after 3 weeks, 4 weeks, child not clinically settling down. CRP is plus minus, child is still having spikes once in a while. In that case, MRI will help. And at that time, if child is already operated, MRI with contrast with plain MRI will not help.
With increasing MRSA, the child may not have local, they might develop pericarditis or some other focal lesion. So that is also, child would be irritable because of that problem. And the parents would take जो surgery हुआ वहीं पे लफड़ा होगा. So that also pediatrician should be counseled for. Yeah.
I think Sandeep, the MRI will take at least 3 months of the time to show the healing changes. So I think MRI is not a very reliable. You have to go by clinical judgment. And there are very rare cases, like I mentioned in my talk, immunocompromised patient because of some other. So one of the patients we had, we just drained out and we were thinking that everything is fine. But when we did on a subsequent follow-up on 15 days, there was big liver abscess also. So I think that's also sometimes can happen. So we have to keep in mind that is.
So I think role of MRI is two. One is in acute situation, we do it. You never do it for follow-up. But if there is a sequelae, see if there is a post-synovitis, if you post-septic arthritis, you don't know whether the hip is dislocated or destroyed.
I think in the interest of time, sorry, I think we'll have to wind up the session. And I thank all my speakers and the panelists. And hope you enjoy the WIROC. Thank you very much.
Thank
you
to
the
everyone.
audience for being here in the morning hours. Thank you.
So,